Today we are going to discuss the topic anti-anginal drugs. So before moving on to the topic proper, let us discuss what is angina. So angina pectoris is a sudden discomfort in the chest and the adjacent areas due to myocardial ischemia. So this happens due to the discrepancy in the demand and supply of oxygen to the myocardium. So there is a discrepancy in the demand and supply of oxygen to myocardium. So because of this decrease in oxygen supply to certain areas of myocardium, we have the myocardial ischemia and we have the anginal pain. So the angina can be divided into different types, that is stable angina, princemetal angina or variant angina, and unstable angina. So the stable anginal pain occurs during exertion, exercise and all, where there is increased cardiac work and the oxygen demand increases. So and because of some obstruction in the coronary arteries caused by the atherosclerotic plaques, there will be no enough blood flow to that area, and during this time of exertion there is increased oxygen demand, and because of this obstruction there will be no enough blood flow. So again a discrepancy in the demand and supply of oxygen takes place and we have the stable anginal pain. And the princemetal angina or variant angina, it occurs due to coronary vasospasm, that is the coronary blood vessels, there will be vasospasm. So there will be no enough blood flow to that area, again ischemia takes place and we have the anginal pain. And in unstable angina what happens is there will be either severe obstruction of this coronary blood vessels because of some acute plaque change, like the plaque rupture causing thrombosis or hemorrhage into the plaque that increases the size of the plaque and causes severe obstruction. So an increased obstruction of the coronary blood vessels will lead to unstable angina. So the pain is felt even at the rest, and the frequency and severity of the pain will also be higher in the case of unstable angina. So now moving on to the anti-anginal drugs. So anti-anginal drugs is mainly used for relieving this myocardial ischemia and terminating this attack of angina. So it does not bring about a change in the coronary, the blood vessel pathology as such. For that we have to use some other drugs like aspirin, ACE inhibitors or statins. But the anti-anginal drugs just helps in relieving that myocardial ischemia and terminating that particular attack of angina. Now moving on to the commonly used drugs in angina. So we can divide them as vasodilators, and cardiac depressants. So the vasodilators is mainly nitrates, and the cardiac depressants is mainly beta blockers. And now we have calcium channel blockers, in which they have both vasodilator effect and cardiac depressant effect. Then we have other drugs like potassium channel openers like nicorandil and other newer drugs. Today we will be mainly discussing about nitrates, calcium channel blockers and beta blockers. So first of all, going on to nitrates. So nitrates, as I already mentioned, they are vasodilators and they mainly act on the smooth muscle cells of the blood vessels. So nitrates. So we have the smooth muscle cells. So once entering into the smooth muscle cells of the blood vessels, they will generate NO, that is nitric oxide, and this will lead to an increase in guanylyl cyclase activity, and this will lead to an increase in cyclic GMP, and an increase in cyclic GMP will lead to dephosphorylation of myosin light chain kinase. So what happens when there is dephosphorylation of myosin light chain kinase? That is, there will be decreased interaction between actin and myosin, and as a result there will be no contraction taking place and there will be relaxation. So it has more of a venodilator effect than an action on arterioles on arteries. So it has main action on veins, that is, it is a venodilator mainly. So because of the venodilator action, there will be peripheral pooling of blood. And there is decreased venous return to the heart, and there is a decrease in the preload, and because of this decrease in preload, what happens is the end diastolic size and pressure decreases. So the end diastolic pressure and size decreases, there is a decrease in preload, so the cardiac work that the heart have to do in order to pump the blood also decreases, and since there is a decrease in the cardiac work, the demand for oxygen decreases and there will be a relief for the ischemia. So it is how the nitrates acts. So it is mainly venodilator and it decreases the preload. And it has some action on arterioles also. So it can bring about arteriolar dilatation and hence it can bring a decrease in total peripheral resistance, but it is not that much important. And another important action of nitrates is the redistribution of, that is favorable redistribution of the coronary blood flow to the ischemic sites. So whenever there is myocardial ischemia, what the nitrates does is that it does not increase the total coronary blood flow as such, but it will redistribute, favorably redistribute the coronary blood flow to the ischemic sites. So it helps in relieving that myocardial ischemia in such areas. So now the mechanism of action is over. Now let us discuss about the main classification of nitrates. Where we have the short acting nitrates, that is glyceryl trinitrate, isosorbide dinitrate, both of them is given sublingually. So the importance of giving them sublingually is that it will help to overcome the first pass metabolism, so there will be rapid action, and the long acting ones are We have isosorbide dinitrate. Here it is given orally. Isosorbide mononitrate, erythritol tetranitrate, and pentaerythritol tetranitrate. And among the orally given nitrates, the isosorbide mononitrate, it undergoes the minimum first pass metabolism. It has more bioavailability and more duration of action, so it is preferred for chronic prophylaxis and all in anginal patients. Now, to terminate and abort an attack of classic angina, we usually use glyceryl trinitrate or isosorbide dinitrate sublingually in an as and when required basis. And all these drugs are mainly used for chronic prophylaxis, not for an sudden anginal attack. Now, other use of nitrates are, so first of all, it is used for angina pectoris. Then it can be used for acute coronary syndrome. Then it is used in myocardial ischemia, and it is used in congestive heart failure. So what is acute coronary syndrome? It is a sudden change in the anginal status of the patient, or otherwise the patient moving on to non-ST segment elevation MI. So in that case, we will try giving 3 tablets of glyceryl trinitrate sublingually in a 5-minute apart duration. Even after giving 3 tablets, if the pain does not decrease or it is not relieved, then we will try IV infusion of glyceryl trinitrate. So these are the main uses of nitrates. Now moving on to the side effects. So the main side effect of nitrates is a fullness in the head. And we can have throbbing headache. Then we can have symptoms like flushing, palpitation, dizziness, sweating and all. And such side effects are accentuated on the use of alcohols and also on erect posture. Now, chronic exposure to nitrates can develop some dependence in the patients. So, gradual withdrawal of these drugs are suggested. Not sudden withdrawal is not recommended. So, that's about nitrates. Now, moving on to beta blockers. Beta blockers are mainly cardiac depressants. So the common drugs we used are propranolol, atenolol, metoprolol, now what they do, they act on beta 1 receptors, which is mainly responsible for action on heart, and it brings about a decrease in heart rate, a decrease in contractility. So whenever there is a decrease in heart rate and contractility, then what happens is again the cardiac work decreases, the demand for oxygen decreases, and there will be a relief of the myocardial ischemia. So this action of beta blockers is not that much pronounced when the patient is at rest, but when the patient is on exertion and exercise and all, these action of beta blockers are more prominent. So they also help in increasing the exercise tolerance in anginal patients. So all these drugs are equally efficient in terminating an attack of angina. That is both the severity and the frequency of the attack of angina. But atenolol and metoprolol, which are selective beta-1 blockers, are more favored in the case of anti-anginal drugs. Now moving on to calcium channel blockers. So we have mainly phenylalkylamines, that is verapamil, benzothiazepines, that is diltiazem, and we have dihydropyridines, that is nifedipine and amlodipine. So the first two drugs, that is verapamil and diltiazem, are mainly cardiac depressants. And the dihydropyridines, they are mainly vasodilators. So what dihydropyridines does is that they again act on the smooth muscle cells of the blood vessels, and if this is one smooth muscle cell, in their membrane they have something known as voltage gated calcium channels. So this is the voltage gated calcium channel, and inside the cytoplasm, that is, we have the sarcoplasmic reticulum where calcium is stored. So these smooth muscle cells primarily depolarize by the entry of calcium through these voltage gated calcium channels, and this entry of calcium through these channels trigger further release of calcium from sarcoplasmic reticulum, and accumulation of calcium within these smooth muscle cells will help in the excitation contraction coupling. So what calcium channel blockers, that is dihydropyridines, does is that it will block the entry of calcium and the accumulation of calcium within the smooth muscle cells. So there will be no enough excitation contraction coupling taking place. So there will be a vasodilator effect. So it causes more dilation in the arterioles than in the veins. So here we have a decrease in afterload. So there will be a decrease in total peripheral resistance, and there will be a fall in BP also. So one important side effect of using dihydropyridines is that it can cause reflex tachycardia because of this fall in BP. So it can cause tachycardia. Then other side effects are angle edema, again headache and all. Now both nifedipine and amlodipine have a side effect known as gingival hyperplasia. Now moving on to verapamil and diltiazem, they causes a decrease in contractility of the heart, and also they decreases the SA node rate, and AV node conduction is also decreased. So hence there is a decrease in contractility and heart rate also. So that is the main action of verapamil and diltiazem. And their main side effect is nausea, constipation and bradycardia. And they are usually contraindicated in patients with 2nd degree and 3rd degree AV nodal block, and also in patients with congestive heart failure also they are contraindicated. And verapamil and diltiazem should not be combined with beta blockers, because both of them have the same action, that is they decrease the contractility and heart rate. So they should not be combined. And both verapamil and diltiazem should also not be combined with digoxin, because they decreases the excretion of digoxin and can lead to its toxicity. So, so that's about calcium channel blockers. Now moving on to an important combination that we use in angina, that is we combine nitrates with beta blockers. So the advantages of this combination is that the nitrates can bring about some kind of tachycardia, which is counteracted by beta blockers, and the tendency of the beta blockers to cause a ventricular dilatation is counteracted by the nitrates. And also the beta blockers have a tendency to cause a reduction in total coronary blood flow, which is also counteracted by nitrates. So combining these two drugs, we can have very good result in the case of angina. So that's about anti-anginal drugs. I hope the topic is clear through this cascade series of full Pass CMC. Thank you.